Welcome back to the Deep Dive. Today we're shifting gears into a very specific high-stakes mode. You've got a stack of textbooks, clinical guidelines, and exam papers right here in front of us. Our mission is clear.
It is. We are acting as your senior MD anesthesia faculty.
And you, the listener, are the postgraduate student getting ready for the Gujarat University MD anesthesiology exams.
Precisely. And we're tackling a topic that is an absolute favorite for examiners. I mean, if you look at past papers, inherited coagulation disorders comes up constantly.
Constantly.
Oh, yeah. It's a classic 20-mark long answer question. It definitely shows up as short notes. And I can guarantee you, if you get a case of bleeding diathesis in your viva voce, this is where the conversation is going.
So no pressure then.
Yeah.
But seriously, this is a massive topic. We're talking hemophilia, von Willebrand disease, and all those other, tricky rare factor deficiencies. It feels like a minefield of Roman numerals and clotting cascades.
It can feel that way, but for the exam, you need a structured approach. It's not about just memorizing lists. We have to understand the pathophysiology, the why, so we can then nail the perioperative care, the how.
Right.
Remember, for an anesthetist, these disorders represent a terrifying risk of catastrophic perioperative bleeding. They mean strict contraindications for regional anesthesia, and you have to get your head around the complex math of factor replacement.
Okay, let's unpack this systematically, just like we would in a written answer. We have to start with the basics. Before we even get to the diseases, we have to understand what's breaking. Let's review hemostasis.
Yeah.
And I see a note here marked very high yield.
It is. You absolutely cannot explain the pathology without the physiology. So hemostasis is broadly divided into two phases, primary and secondary. Think of it like building a wall. Primary hemostasis is laying the bricks.
The bricks being the platelets.
Exactly, the bricks. When you have a vascular injury, the subendothelium is exposed. The first thing that happens is vasoconstriction. That's reflex, neurogenic, and endothelin release. But right away, platelets adhere to that injured vessel wall.
Okay.
And this is crucial for understanding VWD. They need a glue to stick to the wall. That glue is von Willebrand factor, VWF. It acts as a bridge between the exposed subendothelial collagen and the GPI receptors on the platelet surface.
So if you have a problem with the bricks or the glue, say low platelets or a faulty VWF, you get a specific type of bleeding pattern.
Yes, that's the key clinical link. Defects in primary hemostasis, like in von Willebrand disease, typically present with mucocutaneous bleeding.
Meaning what exactly?
Nosebleeds, gum bleeding, heavy periods, easy bruising. It's all superficial bleeding.
Okay, so primary is the bricks and the glue. What is secondary hemostasis?
Secondary hemostasis is the mortar. It's the cement that stabilizes that brick wall. This is where the coagulation factors come in. These proteins, or zymogens, they undergo this enzymatic activation to convert fibrinogen into insoluble fibrin.
And fibrin is the cement.
Fibrin is the cement. It locks that platelet plug in place and makes it stable. So if you have a defect here, like in hemophilia, the wall goes up, but it's unstable. It falls down later.
Which explains the different clinical picture.
Exactly. That's why these patients get deep tissue bleeding, hematomas, bleeding into joints. It's a delayed but much deeper bleed.
And this brings us to the famous coagulation cascade. I remember memorizing that Y shape for my own exams. You have the extrinsic pathway, the intrinsic pathway, and they both meet at the common pathway.
And you still need to know that Y shape for the exam because it's how we understand the lab tests. The extrinsic pathway, which is initiated by tissue factor, is measured by the PT, the prothrombin time.
Right.
And the intrinsic pathway, which involves all those contact activation factors like 12, eolytinia, X, and 8, that's measured by the aPTT.
But wait, I'm seeing a note here about the cell-based model.
Hmm.
Is the cascade, is it outdated now?
Outdated, no. But it's an oversimplification of what happens in vivo. For a high-scoring answer, you should definitely mention the cell-based model. It's the modern concept.
Okay.
It emphasizes that this doesn't just happen in a test tube, it happens on cell surfaces. You have initiation on tissue factor-bearing cells, then amplification on the platelet surface, and finally propagation, which results in the thrombin burst.
The thrombin burst sounds dramatic.
It is. It's the key event. Thrombin doesn't just do one thing, turn fibrinogen to fibrin. It's a massive positive feedback loop. It goes back and super activates platelets, factor V, factor 8, and factor 11.
So it accelerates the whole process.
Massively. And understanding this helps explain why some of our drugs work. For example, recombinant factor eta, which we use as a bypassing agent, it works because it generates that thrombin burst directly on the platelet surface, completely bypassing the missing factors like factor 8.
Okay, that's a really solid physiology foundation. So if you can explain the difference between primary bricks and secondary mortar, and then drop the cell-based model into your answer, you're already setting a strong stage.
You are.
Now let's get into the diseases themselves. We have to start with the exam core. Hemophilia.
Absolutely. This is the big one. Hemophilia A is the most common hereditary cause of serious bleeding. It's a deficiency of factor 8. The incidence is about 1 in 5,000 males.
And hemophilia B.
That's Christmas disease. It's a factor IX deficiency. It's quite a bit rarer, about 1 in 30,000 males.
And clinically, if you have two patients, one with A and one with B, can you tell them apart just by looking at them or their symptoms?
No. And that is a very common Viva trap. Clinically, they're indistinguishable. You can only tell them apart with specific factor assays in the lab.
Let's talk genetics. This is X-linked recessive, right? So it's almost always seen in males.
Correct. Males are affected. Females are typically carriers. However, and this is another point of a detailed answer, don't just assume a female carrier can't bleed.
Why is that?
It's due to something called unfavorable lionization. That's where, by chance, more of the healthy X chromosomes are inactivated in her cells. So she can end up with low factor levels and have mild bleeding symptoms.
That's a great point.
Also, for the exam, you have to remember that about 30% of cases are spontaneous new mutations, so no family history does not rule out hemophilia.
That is a crucial point for taking a patient's history. Now, severity. I know this classification is absolutely critical for management. How do we break it down?
You must memorize these numbers. They are non-negotiable for the exam. Severe hemophilia is less than 1% factor activity. These are the patients who bleed spontaneously into their joints and muscles.
Okay, less than 1% is severe.
Then you have moderate, which is 1% to 5% activity. They'll bleed after what you or I would consider minor trauma.
And mild.
Mild is greater than 5% up to about 40% activity. And these are the ones that really scare us as anesthetists.
Why is that?
Because they might go completely undiagnosed until they have a major trauma or a major surgery. This is the patient who says, oh yeah, I bleed a little more than usual at the dentist. And then suddenly you're in a major abdominal case and the surgical field just won't stop oozing.
Right. And the pattern of bleeding is classic secondary hemostasis, as you said. Deep tissue.
Exactly. Hemarthros, bleeding into the joints, is the hallmark. Over time, this repeated bleeding causes crippling deformities and arthritis. But notice what is absent.
No petechiae.
You do not see petechiae in hemophilia. Why? Because the platelets, the primary hemostasis, is perfectly normal.
Okay, let's move to the labs. We've got a patient who comes in with a swollen, painful knee. What do we expect to see on the blood tests?
Well, his platelet count will be normal. His PT will be normal because the extrinsic pathway is fine. The key finding is that the aPTT will be prolonged.
Because factors 8 and IX are in the intrinsic pathway, which the aPTT measures.
Precisely. So you have a high aPTT and a normal PT. That's your classic pattern.
But you can't stop there.
No. Here is the next essential step for your answer. The mixing study. If you take the patient's plasma and mix it 50-50 with normal plasma, and the aPTT corrects back to normal, what does that tell you?
It tells you something was missing, and you've now supplied it. It's a deficiency.
Exactly. It proves a deficiency. Now, what if it fails to correct?
Then something in the patient's plasma is actively stopping the clot from forming. An inhibitor.
An inhibitor.
Yeah.
An antibody that's neutralizing the factor. And that changes your management entirely.
We'll get to inhibitors in a bit. Let's stick to management for a standard case. I'm the anesthetist. I have a hemophilia. A patient coming for, say, an appendectomy. I need to replace the factor. What is the math?
This is a favorite calculation for the examiner. You need to know this cold. For factor 8, which is hemophilia A, 1 unit per kilogram of body weight raises the plasma level by approximately 2%. The half-life is about 12 hours.
Okay, 1 unit per kilo is a 2% rise.
Now, for factor IX, which is hemophilia B, 1 unit per kilogram raises plasma levels by only about 1%.
Why the difference?
It's because factor IX has a larger volume of distribution. It distributes more into the extravascular space. The flip side is its half-life is longer, roughly 18 to 24 hours.
Okay, so let's do a worked example.
Huh.
I have a 50-kilogram patient with severe hemophilia A, so he has 0% activity. I want to get him to 100% for the surgery.
So you want a 100% rise in his factor level. Since 1 unit per kilo gives you a 2% rise, you need to give 50 units per kilo to get a 100% rise.
50 units per kilo. So 50 kilos times 50 units. That's 2,500 units of factor VIII.
Perfect. That's the answer.
Right.
Now, what if it were hemophilia B? Same patient, same target.
Okay, for hemophilia B, 1 unit per kilo only gives a 1% rise. So to get a 100% rise, I'd need 100 units per kilo. 50 kilos times 100, that's 5,000 units.
Exactly. That's the kind of concrete, calculated answer that gets you full marks.
Okay, that's clear. Now let's pivot to the other big one on our list, von Willebrand disease. The outline here says this is a very high-yield exam favorite. Why is that?
It is, and the reason is because it's actually the most common inherited bleeding disorder. It affects up to 1% of the population. But it's often much milder than hemophilia, so it can be subtle.
We mentioned before that VWF is the glue for platelets, but you said it has a second job, right?
Yes, and this is the aha moment for understanding VWD. VWF has a dual function. It's really important to state this in your answer.
What's the first function?
First, as we said, it mediates platelet adhesion. That's its role in primary hemostasis.
And the second?
Second, it acts as a carrier protein for factor VIII. It chaperones it in the circulation and protects it from being broken down and cleared too quickly.
Oh, I see. So if you have low VWF.
If you have low VWF, your factor VIII level also drops because it's unprotected and gets degraded. So a patient with severe VWD can present with lab findings that look a lot like mild hemophilia A.
That explains why the labs can be confusing. Let's look at the types. I know there are 3 main types.
For the exam, you need to understand them conceptually. Type 1 is a quantitative deficiency. You make the protein, just not enough of it. This is the most common form, usually autosomal dominant.
And type 2.
Type 2 is a qualitative defect. The protein is there, but it's dysfunctional. It doesn't stick right, or it doesn't bind factor VIII correctly. There are subtypes like 2A, 2B, but you just need the general concept.
Type 3 must be the worst.
Type 3 is severe, a virtual absence of VWF. These patients have a double whammy. Their primary hemostasis is shot, and their factor VIII levels crash to severe hemophilia levels.
So what are the clinical features for the more common types?
It's that mucocutaneous pattern we talked about. Epistaxis, nosebleeds, menorrhagia, gingival bleeding after brushing teeth. It looks like a platelet problem.
So the laboratory findings for VWD would reflect that.
They should. The bleeding time, or more modernly the PFA 100, which is a platelet function analyzer, will be prolonged because primary hemostasis is broken.
What about the aPTT?
The aPTT might be normal in mild cases, or it could be prolonged if the factor VIII level has dropped significantly because of the low VWF carrier. The PT will be normal.
So to really nail the diagnosis,
You need specific assays. You measure the VWF antigen level, that tells you how much is there, and you measure its function using something called the ristocetin cofactor activity assay.
okay, and management. This is where that drug Desmopressin or DDAVP comes in, right?
Yes. DDAVP is a synthetic analog of vasopressin. It works by stimulating the endothelial cells to release their pre-made stores of VWF and factor VIII from the Weibel Palade bodies.
So it's perfect for type 1.
It's great for type 1 because they have stores, they just don't release enough. It's useless for type 3 because they have no stores to release.
What's the dose we should know?
The standard dose is 0.3 micrograms per kilogram, given IV. But there are a couple of very important caveats you must mention.
Okay, what are they?
First, tachyphylaxis. The response diminishes with repeated doses because you deplete the stores. You can't just keep giving it every few hours. Second, it has an antidiuretic effect, so it causes water retention. You have to watch the patient's sodium levels for hyponatremia.
Right, that's a key safety point. And if DDAVP isn't enough, or if it's a patient with type 2 or 3 VWD.
And then you need to give them a factor concentrate that actually contains VWF. You can't just give pure factor VIII. You need the specific VWF-containing concentrates, or now recombinant VWF.
Okay, we've covered the big 2. Let's do a quick fire round on the other coagulation factor disorders. First up, factor HIV deficiency.
Also called hemophilia C, it's more common in the Ashkenazi Jewish population. The trick here, the thing examiners look for, is that bleeding severity does not correlate well with the factor levels.
What do you mean?
A patient can have very low levels and not bleed much, or have moderate levels and bleed a lot after surgery. It's unpredictable.
Okay, next, factor VII deficiency.
This one is rare, but it gives a very clean lab pattern. It's the only single-factor deficiency that prolongs the PT but has a completely normal aPTT.
And finally, factor 13th deficiency. You said this one is a classic exam trap.
Oh, examiners love this one. Remember, factor 13 doesn't help form the clot. It comes in at the very end to stabilize the fibrin clot by cross-linking it.
So the clot forms normally.
The clot forms at a normal speed. Therefore, the PT is normal, the aPTT is normal, the bleeding time is normal, all your screening tests are normal.
But the clot is weak.
The clot is weak and fragile, so the patient presents with delayed bleeding maybe 24 to 36 hours after surgery or trauma, or with poor wound healing. The classic textbook sign is prolonged umbilical stump bleeding in a newborn.
And the diagnosis is a special test.
Yes, you need a clot solubility test where you see if the clot dissolves in a urea solution.
That's a great clinical pearl.
Yes.
Delayed bleeding with normal labs. Okay, moving on to differential diagnosis. How do we quickly separate platelet disorders from coagulation factor disorders in a high-pressure VIVA?
You look at the pattern of bleeding, it's all in the history. For platelet or vessel wall problems, primary hemostasis, you get petechiae, superficial bruises, and mucous membrane bleeding. And the bleeding starts immediately after the trauma.
And for the coagulation factors.
For secondary hemostasis defects, you get deep hematomas and hemarthrosis. And importantly, the bleeding is often delayed because the initial platelet plug forms, but then it fails because it isn't stabilized by fibrin.
What about sorting out congenital versus acquired bleeding disorders?
History is king. You have to ask about the age of onset. Bleeding since childhood. That points to congenital. Family history. Did they bleed after their tonsillectomy or a tooth extraction? You have to remember, acquired causes like liver disease, vitamin K deficiency, DIC, or medications are statistically far, far more common. But for this specific exam question, we're focused on the inherited ones.
Let's talk about the toolkit. Investigations. We touched on PT and aPTT. Let's just solidify that.
Okay. PT, or prothrombin time, assesses the extrinsic pathway, so factor C5, and the common pathway, which is factors X, V, 2, and fibrinogen.
And aPTT.
aPTT, or activated partial thromboplastin time, assesses the intrinsic pathway, so 12, 11, X, 8, and also the common pathway.
So if both are prolonged, the problem is in the common pathway.
Or you have multiple factor deficiencies, like in liver disease or DIC.
What about point-of-care testing? The outline specifically mentions TEG and ROTEM as very high yield. This feels like a more modern exam topic.
It's crucial for modern anesthesia exams. You need to be able to describe a TEG or ROTEM tracing. These are viscoelastic tests. They give you a global picture of the entire process: clot initiation, strength, and lysis.
And for hemophilia, what does the tracing look like?
The classic description is a champagne flute. The R time, or reaction time, is very long. That represents the time to initial clot formation, and since the factors are low, it takes forever to get started.
So a long R time points to a factor problem.
Yes. And if you see a long R time, your treatment is FFP, or specific factor concentrates. The rest of the trace, like the MA, or maximum amplitude, which reflects platelet function, might be okay if the platelets are normal, but often the whole trace is thin and weak.
And what if the MA is low?
A low MA means a weak clot, and that points to a problem with platelets or fibrinogen. So you treat with platelets or cryoprecipitate.
And if it looks like a teardrop?
A teardrop shape, where the clot forms and then rapidly narrows, that's hyperfibrinolysis. The clot is being broken down too fast. Your treatment there is an antifibrinolytic, like tranexamic acid.
It's a champagne flute for hemophilia.
Mm-hmm.
Right, that visual. Okay, let's get to the real meat of the matter for us. Perioperative management.
The preoperative assessment is the single most important step. History, as we said, is the most effective predictor of bleeding risk. You have to ask specific questions.
Yeah.
Do you bleed when you brush your teeth? How long did you bleed after your last tooth extraction? Is there any family history of bleeding problems?
Do you have to work with a hematologist?
Mandatory. This is not a solo flight. You must have a clear, coordinated plan with the hematology team.
And what about optimization? What are the targets?
Well, for major surgery, like an orthopedic joint replacement, which these patients often need because of chronic hemarthrosis, you need to raise their factor VIII or IX levels to 100% pre-op. And that's not all.
Rails.
You need to maintain those levels above 50% for days or sometimes even weeks post-op to allow for proper healing.
Okay, so intraoperatively.
Meticulous, perfect surgical hemostasis. The surgeon cannot be sloppy. You cannot rely on the body to stop the bleeding. Also, simple things from our side. Avoid intramuscular injections at all costs. They cause nasty hematomas.
Right.
Be extremely careful with positioning to avoid pressure trauma. And monitoring. Standard labs like aPTT are too slow to guide you in the middle of a surgery. This is where TEG or ROTEM is so valuable for real-time guidance.
Let's talk about the pharmacological adjuncts. Antifibrinolytics like tranexamic acid.
Yes. TXA or epsilon aminocaprylic acid. These are very, very useful, especially in mucosal surgeries like dental work or oral surgery. Saliva is rich in fibrinolytic enzymes that naturally break down clots. Tranexamic acid blocks that process and helps stabilize the clot.
Now for the big anesthesia question, the one every trainee worries about. Can I do a spinal or an epidural?
Regional anesthesia, specifically neuraxial blockade like a spinal or epidural, is generally considered contraindicated in patients with a significant coagulopathy.
Why?
The risk is an epidural hematoma. A bleed in that closed space can compress the spinal cord and cause permanent paralysis. It's one of our biggest nightmares.
Is there ever any exception to that rule?
It's extremely controversial. It may be considered if, and this is a huge if, the factor levels have been completely normalized and documented, usually to above 50%, and the coagulation profile is otherwise normal. But it requires extreme caution and a very careful risk-benefit analysis with the patient and the whole team.
So for the exam, the safe answer is?
The safe answer is avoid it unless absolutely necessary, and the patient is fully optimized, and the benefits clearly outweigh the very serious risks.
What about airway management? Any special precautions?
Yes. Avoid nasal intubation. The nose, particularly Kieselbach's plexus, is extremely vascular. Trauma there can cause severe epistaxis that's very hard to control, and you need to be very gentle with laryngoscopy to avoid causing an airway hematoma, which could be life-threatening.
Okay, we have to talk about complications. What are the big things that can go wrong in the long term?
The biggest fear in the chronic management of these patients is inhibitor development. This happens in about 30% of patients with severe hemophilia A. They develop antibodies against the infused factor VIII.
So their replacement therapy just stops working?
Exactly. It's a nightmare scenario, especially if they present for emergency surgery. Your standard treatment is useless.
How do you manage that?
You need to use what are called bypassing agents. These are drugs that, well, bypass the need for factor VIII. The main one is recombinant factor VIII, or RFVIII. It directly activates factor X on the platelet surface and gets the thrombin burst going.
Okay. And of course, there are always the general risks of transfusion.
Absolutely. Historically, viral transmission of HIV and hepatitis C was devastating for this population. Recombinant factors have made it much, much safer now. But we still worry about things like transfusion reactions, volume overload, or TACO, and transfusion-related acute lung injury, FERLI.
We're nearing the end of our deep dive. Let's hit the common exam questions and Viva traps. What are the specific things examiners like to ask to see if you're really thinking?
Okay, trap number 1, the normal aPTT. They'll say, you have a patient who you know has hemophilia, but his aPTT comes back normal. Explain.
And the answer?
It's mild disease. If the factor activity is above about 30 or 40%, some of the less sensitive aPTT regions in the lab might not be able to pick up the abnormality.
Trap number 2.
Hemophilia A versus B. They'll ask, can you tell them apart clinically?
The answer is no.
The answer is absolutely not. Never guess. You need the specific factor assay.
And trap number 3.
The bleeding child with normal screening tests. They give you a scenario of a child who had a tooth out and bled for 2 days, but the PT and aPTT are normal.
That's our factor 13th deficiency.
That's your top differential, factor 13th deficiency, or possibly a platelet function defect, which would require a different set of tests.
And finally, presentation. If this is a 20-mark written exam, how should you structure the answer to impress the examiner?
Structure is everything. Use headings, introduction, pathophysiology, clinical features, investigations, perioperative management, and use visuals if you can.
Like what?
Draw the coagulation cascade. The simple Y shape is fine. Label where factor VIII and IX are. Draw a simple TEG tracing, showing a normal one next to the champagne flute of hemophilia, and maybe a simple diagnostic algorithm in a flowchart. Symptoms lead to PTAC-TT, which leads to a mixing study, which leads to a factor assay.
And it's always good to throw in a recent advances section if you can, right? Maybe mention gene therapy or the new, longer-acting recombinant factors.
Exactly. It shows you're not just reading the old textbooks. It shows you're engaged with the current state of the specialty.
Okay, so to wrap up our exam prep session and give a final summary, inherited disorders are genetic defects in clotting factors or platelets.
Hemophilia A and B mean deep tissue bleeding, a prolonged aPTT, And you manage it with specific factor replacement.
Von Willebrand disease means mucocutaneous bleeding, a prolonged bleeding time, or PFA 100, and it often responds to DDAVP, or needs a VWF-containing concentrate.
Pre-op history is your single best tool for assessing risk.
Avoid neuraxial anesthesia whenever possible.
And this is always, always a multidisciplinary team effort with the hematologists. Safety first.
Before we sign off, here's a final provocative thought to take with you. We talked about the cell-based model of coagulation and how it's not just a domino effect of proteins in plasma, but a complex interaction on cell surfaces. As gene therapy and cellular engineering evolve, are we moving toward a future where we don't just replace the missing protein, but we actually reprogram the patient's own cells, maybe endothelial cells or hepatocytes, to become the factories that produce the factor they're missing?
Something to mull over. It's the future of the field. Good luck with the Gujarat University exams.
Check the show notes for those diagrams we mentioned. Good luck and keep learning.